Okay, great question. So when you, the question was on those holes in the bone. Those holes are not holes. It's the pattern of the bone. The bone is just irregular, as if somebody took their nails and just made like a couple of scratches. It's very irregular. The tissue is very densely attached. So I don't fill them. I actually reduce the whole thing. I reduce, that's excess bone. You don't need it. And that will prevent the tissue from growing back. That's called the bone reduction and reshaping. So don't fill them. You remove the whole thing. Okay. Any more questions? Yes. We got some questions from the online people watching us right now.
When doing veneers, what's the formula for splitting the difference between incisal lengthening versus gingival recession?
Great question. So that's like that's the million-dollar question that mostly technicians can answer with a diagnostic wax-up and a virtual simulation. What's the balance between doing crown lengthening and incisal edge position? So I'd like to say it all starts with the incisal edge position, period. Start there. Decide on your ideal incisal edge position, because that doesn't change. That's where dentistry starts, really. Whether you're doing a denture, a full mouth rehab, or a single veneer. Figure out the incisal edge position, then figure out the proportion you'd like to have, and that will determine the amount of tissue resection if you need it. I mean, I've seen many cases that came to me for aesthetic crown lengthening, and I didn't do it. I asked the dentist, how much are you going to lengthen the teeth? So if they're lengthened, all of a sudden the tooth looks normal, they don't need me. I could use the production, but I'm going to mess them up. So we don't want that. Larry, you have some questions.
Well, first of all, I want to congratulate you on a very organized and simplified clarification of aesthetic crown lengthening. From a restorative perspective, and looking at total facial aesthetics, looking at a smile, because we're looking at smiles, not just gingiva, it's really important what you just said. Incisal edge position is important. So what is the ideal incisal edge position? If you look at denture aesthetics, we look at phonetics and aesthetics, we have to have function, we have to have the ability to speak. With today's advent of ability to alter lip position, lip length, lengthening, we also have to understand what is the length of an upper lip. If we understand that we have a normal tooth exposure in repose of 2 to 4 millimeters, depending on race, gender, and age, we have to analyze that. Is the tooth unworn? Is it a worn patient? Is it a young patient? Is the upper lip the proper length? What do we do if we think about denture aesthetics in measuring the incisal edge position? The normal range is 18 to 22 millimeters from the depth of the upper sulcus to the incisal edge. So we really have to start looking at things from an orthognathic standpoint, from a plastic surgical standpoint, from the age of the patient standpoint, function, and phonetics. We do start with the incisal edge position. Once we've established that that is within the range of norms and we don't have a VME or vertical maxillary excess, again, measure the depth and the length of the upper lip or the alveolar process in the incisal edge of the teeth. Or do we have a hypermobile lip or a short upper lip? If it's a hypermobile lip, sometimes things like Botox can help that if it's a normal length lip without doing any restorative, without any surgery. If the tooth proportion is out of whack, then we need to do exactly what Dr. Simon said and measure the incisal edge to the gingival zenith. If the central incisor is 10.5 to 11 millimeters long, generally 9 millimeters wide, we measure that proportion. Do we do gingivectomy or do we do osseous crown lengthening? Again, that depends upon bone position. How do we know the bone position? We sound to bone. With anesthesia, we take a periodontal probe, open the gingival margin, insert it until we reach bone. 3 millimeters or less, then we're probably going to need osseous crown lengthening. If we have delayed passive eruption of 5 millimeters or more, we could probably do some gingivectomy without expecting any rebound or relapse of the gingival tissue. Interproximate is usually 5 millimeters in depth. Labial, usually about 3 millimeters depth. So there's a number of concepts that we need to think about in the total smile not just doing tooth proportion or gingival display. Gummy smiles have a need for multiple diagnostic differential diagnosis. VME, worn teeth, incisal edge position, long upper lip, short upper lip, working as a team, restorative with periodontists, plastic surgeons even, and of course the laboratory will give us the best diagnostic tools to be able to decide what we do, when we do it, and what sequence that we do it in, and who does what first. So I just want to make that comment because I've gone through this many, many times. One last comment. You mentioned 6 to 8 weeks, and that may be correct. The older literature by MDY said 20 weeks is ideal for complete histological maturation following crown lengthening or osseous surgery. So if there's any new literature, I would love to hear that one. Thank you for a beautiful presentation.
I appreciate it. That was all planned to give me an opportunity to drink coffee. Thank you. That was a nice bonus comment. Sam, from a lab technician from Beverly's Dental Lab, when we worked on aesthetic crown lengthening cases, what was your experience, good and bad, in terms of the planning?
Well, basically, it all depends on the data collection, which is topography of the patient, the lip movement, and the diagnostic design of the case. And it has to be a facially driven decision how the teeth will look. It has to fit the patient's face, smile. Sometimes the patient are their own enemy, you know. They want perfection, but it won't work in their cases. So it's basically a facially driven decision how the teeth should look.
Thank you. And it's invaluable to collaborate with a dental technician. I run my implant planning not just by the dentist, I run them by the technician that will restore the case. Same with aesthetic crown lengthening. I wanted to just double check because we want to think twice and cut once. That's a common saying in surgery. Any more questions? Yeah, questions from the online.
Do you do the frenectomy before or after the crown lengthening?
That's a great question, and it gets so much into the technical aspect of crown lengthening by design. Very often, you have a frenum position that is normal for delayed eruption. Once you start resecting tissue, suddenly the frenum becomes aberrant. It becomes closer to the gingival margin. I like to resect it at the same time. And it's tricky. Why? Because once you resect the frenum and you have a full thickness flap, by definition, you can perforate the flap. So there's a trick to it that I'm not going to get into, but you have to be parallel with the flap to leave the periosteum unperforated. Less perforations are better. More questions? Yeah, we have a couple hundred people watching us right now, so that's great interaction.
How much should we be worried that the gums are going to recede on our veneers, post crown lengthening, and veneers?
Be worried about our soft tissue receding after veneers. I'm not sure I call it worry. I mean, I think it's always a risk. We have patients that are prone to recession, and of course, if you create restorations closer to the soft tissue, to the gingival margin, they can recede more. It's just part of what we do. Sometimes they can recede. Regardless of the crown, it has nothing to do. They would recede anyhow. The question is, if you over crown lengthen, what happens then? And I showed you one complication that was managed. We don't like to worry. I don't worry. It's just not one of those. Worrying doesn't help you, number one. Number two, worrying is a trait of somebody who has a fixed mindset. They worry. When good things happen, they're happy. When bad things happen, they're sad. It's one of those fixed mindsets that we have to stay away. And we all have it, by the way. But we have to stay away from them, because if your whole happiness depends on a patient that had recession or a veneer that broke, then you got to get into a different mindset. And we have tons of problems in our profession, whether they're technical or patient-related or biological. We have tons of those problems, but we don't worry about them. We try to solve them. We address them. That's a growth mindset. Not everything that you do is going to be perfect. Actually, very little is going to be perfect. I talked about perfectionism. Remember, it's trying to fool the world that you are something that you don't even believe in. It's very self-abusive. You know, you got to get out of it. I'm recovered. I recovered from that already. Perfectionism. Rebecca.
Age restrictions similar to how implants would be for a certain age?
That's a very apropos. Do we have age guidelines for crown lengthening? So I personally, with delayed eruption, you can go in there or do the procedure as early as 15, 16, mostly with female patients compared to male patients. Because delayed eruption, the term itself is very confusing. Why? Because the word delayed. Delayed means, you know, we're late, we're delayed, it's going to happen in a year. No, it just doesn't, it'll never happen. So you can go in them pretty early. We treat patients in their 20s, in their 30s, in their 40s, in their 60s. And one of the common things that keep coming back from patients is the following. You know, I never knew something can be done. I thought my teeth are that short. I never knew until, you know, my dentist told me, actually, you got to see these guys and they can lengthen improve the proportions. So age, we can go in pretty early as compared to implants. The implant restriction is a completely different reason. And now we even are actually much more strict. We push the implant into the future as much as we can, or don't even do it, as much as we can. We have other problems with implants. In the next lecture, we'll talk about implant problems. More questions? As we wait for the dessert to come, we keep busy with questions.
I have a patient that has an implant in the premolar area that is integrated but generating pus. I need to open his bite and do crown lengthening on it to achieve the result I'm envisioning for him. How do I handle the pussing implant in the sequence of giving him a great smile?
It's a great topic. It's a great topic. I'm not sure we can solve this problem here without more data, but let's talk in principle. When you have a pussing implant, it's not a good thing. Number one. So that we know. It's not a good thing, and you have periimplantitis. So the number one goal is not aesthetics, is to keep this implant alive. And there's a treatment protocol that actually we talked about in the last lecture of how to treat periimplantitis on its different forms. So the mindset would be, for this type of case, first of all, go through the protocol to treat periimplantitis. Stop the separation if possible, stabilize the implant, and only then think about aesthetics. The challenge you would have is that you cannot crown lengthen the implant. The platform is where the platform is. If you resect tissue, even if you reflect tissue, and definitely if you remove bone, that would be counterproductive. So I always like to separate these two things. Okay, it's like the question is, what's the best way to, invest $1 million? What's the best, what's the first thing you do? First, you get the $1 million. Okay, that's one thing. What's first is first. Okay, so that's my answer. Okay, and for more for this doctor asking the question, please share the more clinical information so we can be more specific. Okay, just to spend some time here in front of you, just nothing to do with the lecture. There is a brochure about an endo conference. I don't have any intentions to go. That's not my goal, but I'm addicted to education. And Rashad and myself, together with Dr. Ilan Watson, who was here before, we are organizing an endo conference coming up this year. So if you have any interest in endo, whether doing it or performing it or listening to great speakers from around the world, it's a great opportunity. It's not too far. I know it's city of industry. Doesn't sound great. No offense, but the speakers are going to be be amazing. And we're dedicating this conference to Dr. John I. Ingle, who passed away 2 years ago. And this whole conference is in his spirit. His spirit is going to be there. Okay, we're ready. And the website is endosymposium.com. Okay, and please join me in singing happy birthday to Dr. Mitch Levitt. Happy birthday to you. Happy birthday to you. Why me? Happy birthday, Dr. Mitch. Happy birthday to you. Thank you. Anybody else celebrating a birthday? That's one of the perks. Come around your birthday and you'll get a free dessert. Excellent. Thank you all again for attending. We appreciate your confidence in Ari and myself and working together for so many years. You can see that we are pretty relentless in our efforts to educate and collaborate and share with you everything that we do, and we're learning from you as well. So thanks again. You can turn on the music if you have, and stick around. Thank you.
Thank you. That was great.
I appreciate it.